Good afternoon. It's 2 o'clock. We will start. First of all, I would like to welcome everybody. So instructions, please mute yourself, but always show your video picture. Sign in your name, Facebook account, or email address in the chat box. Please include names of the companions attending. Use the chat box to ask questions and make comments while the pep talk is on. There'll be group pictures at the start and at the end of the pep talk. So please show your face in the video. As a reminder, please take the online learning cum evaluation test exercise, OLETE, for mastery of learning, and have a perfect score to get a certificate like the one shown below. Okay. I have placed the link in the chat box already. So let me just inform you that as of August 14 today, okay, there were already 28 who completed the OLETE, okay, from the start up to this as to last time, okay, last week. Thank you and congratulations. Okay, so this number is compared to 22 as of last week. No? So as I said, my target is at least 30. So I'm reaching my target of 30 patient-empowered people. So let's now have a group picture taking before we start in 2 minutes. Okay. 1, 3. Okay, ready? 1, 2, 3. Okay. So let me save it in my computer first. So let's have it. I think there are 2 pages. Let's have another one. Please show your face. Please show your face. Glenn, Gemma, Emelita, Tan. Okay, 1, 2, 1, 2, 3. Let's start. I have a patient empowerment program in which I like to empower the lay people or patients to take control in the management of their health. What I have in mind in my pep talk, which may run for 3 years, is to empower at least 30 persons with my family members and my patients as a priority. This is my key performance indicator. I hope you will be within this group of 30. I launched this pep talk on May 15, 2021 with the module on COVID-19. The second module was on patient empowerment. I'm now on my third module, patient management process. There are 6 parts in this module: overview, clinical diagnostic process, paraclinical diagnostic process, selection of treatment process, advice to patient process, and peculiarities and limitations of medical practice. We are now on this last session, peculiarities and limitations of medical practice. Again, this is the patient management process framework that we have been discussing for the last 5 weeks or 6 weeks. Okay. So my pep talk today will be entitled Peculiarities and Limitations of Medical Practice. The empowerment objective is for the lay people or patients to have an understanding of the peculiarities and limitations of medical practice that affect the patient management process. The patient management process is essentially problem solving and decision making of a patient's health concern. It is a very complex process in that one, it involves a lot of steps like diagnosis and treatment and advice. And in each step, there is a series of actions which are carried out in order to achieve a particular result or goal. And that's the reason for calling this the patient management as a process. Second, although there are guidelines in the use of the processes in achieving a particular goal, implementing them do not always ensure attainment of goals. The main reason for this is that there are peculiarities and limitations in the science of medicine and its practice that pose challenges and hindrances in accomplishing the goals 100%. All physicians are fully aware of these peculiarities and limitations and have adjusted to them and have factored them in their management of their patients. All patients or lay people like you should also be made aware of, at least, if not fully understand, these peculiarities and limitations so that they can adjust to them and factor them in their management of their health concerns and issues. This awareness will also facilitate their participation in the problem solving and decision making with their physicians, in the sense that both parties are aligned in the understanding of the peculiarities and limitations of the science of medicine and its practice. By the way, when I am using the word peculiarities in the title, okay, I use it to mean eccentricity. That is, deviation from the established pattern or norm or from the usual. I may also use it to mean idiosyncrasy, that is, unusual feature or behavior. I am using the word limitations in the title to mean the greatest amount, greatest extent, degree of something that is possible or allowed, but not able to achieve the full capability. As we discuss this topic, please have in mind the patient management process as shown on the center of the screen. At the same time, have in mind the peculiarities and limitations of the science and practice of medicine and see how the latter affect the former. So these are the maxims, rules, and guides in the management of the patient in consideration of the peculiarities and limitations of medical practice. First maxim is medicine is an inexact science. I repeat, inexact science. Medicine is an art of probability. There are a lot of uncertainties here. Anything is possible, but we usually use the art of estimating the probability of things. The ideal goals or fighting targets in patient management by physicians are the following: resolution of the health problem in such a way that the patient does not end up dead, with no complications and no disability as much as possible, and in such a manner that the patient is and the relatives are satisfied. Now, because of the limitations of medicine, the ideal goals or targets in patient management cannot be achieved all the time. What is most important is that the physicians exert their best, rational, honest, humane, or compassionate efforts in managing patients to the satisfaction or delight of the patients, even in the absence of complete resolution of the health problem. Fifth maxim is best effort by physicians at all times, cure sometimes, relief often, comfort always. Nothing is absolute in medicine. There are exceptions to the rules. Anything is possible. There are more than one way of doing things in medicine. There is no such thing as absolutely certain diagnosis, whether it be clinical, meaning using sign and symptoms, paraclinical, using laboratory, histopath, and or post-mortem diagnosis. Even the diagnosis at death is not totally absolutely certain at times. The only routine in medicine is a rational decision making in the management of a patient with a health problem. Rational decision making weighs the probability of being successful in the achievement of the goals of the management of the patient. Rational decision making relies more on the general rules rather than on the exceptions. It banks on the more common rather than on the least common or rare events. It uses processes rather than gut feel. It may not always be correct. As long as the decision making is rational, it is acceptable. Irrational decision making is more often correct than wrong compared to an irrational decision making. As to the diagnostic process and the diagnosis, some of the maxims, rules, and guides here are: the diagnostic process must be rational for it to be acceptable. A diagnosis that is based on the rational process is not always correct, as mentioned. However, a diagnosis is more often correct than wrong if it is rationally arrived at. A diagnosis is almost always an educated guess. An educated guess. As to interview as a diagnostic tool, identify the chief concern or main problem of the patient. Once it's identified, we use it as a steering wheel in the diagnostic investigation of the patient. Inquire on the circumstances associated with the chief concern. Inquire on the symptoms. Symptoms are defined as those manifestations perceived by the patient in terms of feeling, in terms of observation. Get clues from the circumstances and symptoms to be used in the diagnosis of the patient. Be effective, be complete, be efficient, be relevant. Then know how to get cues from the data and know how to interpret the data. Know which data to pursue, which data to put in the background, to use in the diagnosis, and not to use in the diagnosis. Physical exam as a diagnostic tool. Use again the identified chief concern or main problem of the patient as a guide on what to examine. Okay, that's why doctors usually from the very start ask the patient, what is your main concern or main problem for coming to see us? Okay. So that's the starting point of everything. Okay. So use that and then look for signs. Signs are those manifestations perceived by the physicians, in contrast to symptoms, which I defined earlier. So these are felt or observed by the patient. Symptoms. Get clues from the signs to be used in the diagnosis of the patient. Be effective, be complete, be efficient, be relevant. Know how to get cues from the data of the signs and then how to interpret them. Know which data to pursue, to put in the background, to use in the diagnosis, and not to use in the diagnosis. As to interview and physical examination, which are the main tools in the clinical diagnosis, so interview and physical examination can be done in any order as dictated by the circumstances. Interview and physical examination can be done simultaneously. The goal of the interview and physical examination is diagnosis, clinical diagnosis. Correlate data from the interview and physical examination to come out with a rational clinical diagnosis. If there is a question on which data to put more reliance on, we usually choose the sign data over the symptom data because sign data are more reliable. But to be reliable, they must be accurate. And they must be accurately derived at by the physician. The clinical diagnostic process. A clinical diagnosis is one that is derived from interview, getting the symptoms, and the physical examination, getting the signs, or put it in another way, one that is derived from the symptoms and signs. Essentially, the two processes used in coming out with the clinical diagnosis are pattern recognition and prevalence. So pattern recognition just means the realization that the patient's presentation conforms to a previously learned picture or pattern of a disease. Whereas prevalence means the choice of a diagnosis is based on the frequency of occurrence of the disease in a certain locality, in a certain age or sex group, in the affected organ and system, and I would like in a certain time, just like today, we are in the era of COVID-19 pandemic. So we have to put that into consideration when we have symptoms of upper respiratory tract infection. The elemental steps in making a diagnosis: identify which organ, tissue, or system is involved, then identify the disease in general terms such as inflammation, infection, tumor, trauma, endocrine, etc. Then try to be more specific in identifying the disease, if possible, such as malignant neoplasm, abscess, etc. Knowing the nomenclature of diseases facilitates the diagnostic labeling. As to the paraclinical diagnostic process, so after the clinical diagnosis, the next step is to determine whether a paraclinical diagnostic procedure is needed or not. A paraclinical diagnostic procedure is a diagnostic procedure that is done after the clinical diagnosis is arrived at, and its objective is to make the clinical diagnosis more definite, more certain. To decide whether a paraclinical diagnostic procedure is needed or not, a physician should consider the following factors: how certain he is with the clinical diagnosis, whether a more definite diagnosis is needed or not for one reason or for some reasons or another. Once a decision is made that a paraclinical diagnostic procedure is needed, the next step is to choose the most cost-effective procedure for the patient by doing the following. The physician usually or should tabulate, compare, and analyze the options listed on the first column and give the so-called BRCA data like this. B stands for benefit, R stands for risk, then C, cost, then availability. Putting priority on benefit, then risk, then cost, availability in that order of descending order. Okay. After the paraclinical diagnostic procedure has been done, the next step is to interpret the result. The result of the paraclinical diagnostic procedure must be correlated with the signs and symptoms of the patient to come out with a pre-treatment diagnosis or a diagnosis just before the treatment. Selection of treatment process. The selection of treatment procedure is based primarily on the pre-treatment diagnosis. Select the most cost-effective treatment for the patient by doing the following: tabulating, comparing, analyzing the different options, place in the first column, and then give the BRCA data, okay? Benefit, risk, cost, and analysis. The final decision on the type of treatment to institute will rest on the patient. So the doctors will have to get the informed consent or informed refusal if the patient does not want to. I will now go to the two special issues related to the limitations of doctors or physicians. Knowing when and to whom to refer, and then the other issue is second opinion. Let's start with knowing when and to whom to refer. There will always be patients whose health problems will be beyond a physician's existing competencies. Such patients may have a very unusual health problem whose diagnosis is extremely difficult. Such patients may have usual health problems, but whose treatment is beyond a physician's existing competencies. For example, a primary care physician, or the usual terminology used here is GP, okay, who has not been trained to do surgical operations. True to all physicians, regardless of the amount of training and experience, there will always be patients whose health problems are beyond their present existing competencies. This applies to me also. So when to refer, all physicians must know their limitations. Only they themselves can determine their own limitations. They must realize their limitations so that they do not cause undue harm to their patients, and so that they know when to refer to their colleagues. When you say refer, it means asking for help from and conferring with medical colleagues. Referring a patient to a colleague may mean totally transferring the care of a patient to him or continuing to manage the patient with his help. Whichever way, a proper communication, either oral or written, is in order. Referral must be made to somebody who may or can solve the patient's health problem rationally, effectively, efficiently, and humanely, and who has a good track record of handling the kind of problem on hand. Now let's go to second opinion. Second opinion means seeking another opinion on patient management from another physician or healthcare professional. It can be sought by both physicians and patients. Physicians seek second opinion from medical colleagues when they realize their limitations, when they are beating their heads against the wall in trying to know the true diagnosis and how best to treat the patient. Physicians can informally communicate with their medical colleagues from whom they want to seek an opinion, or they can formally advise the patients by giving a referral letter to seek a second opinion from another physician. Patients on their own free will seek second opinion from another or other physicians for at least two valid reasons. First reason is they are not fully satisfied with the explanation of the first physician, either because there is no or incomplete or no or unclear explanation. The second reason for patients seeking second opinion is that they want to validate the explanation and recommendation of the first physician. The usual scenario is because they are hesitant to accept the recommendations, and they hope there will be different recommendations from the next physicians congruent to their personal desire. Here is a special note. Seeking another physician is not always equivalent to seeking second opinion. Seeking another physician may have other reasons aside from second opinion. An example, Patients may be primarily shopping for physicians who can offer the best or especially affordable medical expenses. Another example, they may be looking for other physicians whom they can communicate better and with whom they have better rapport, trust, and confidence compared to the first physicians. The third example is that they may be looking for other physicians because of convenience of continued medical care, such as physical proximity of the clinics of the physicians and their affiliated hospitals. All patients have the right to seek second opinion for whatever reasons they may have. Nobody will, can, and should question the reasons. So the basis for this right is that patients have the right to make their own choices and be the primary decision maker with regards to their health concerns and issues. They have the right to seek medical opinions from another physicians after the first and to as many physicians as they want. But the foremost objective, valid indications for second opinion should be if the first physician is not explaining or advising well using the rational patient management process and the diagnosis and treatment. So this should be the most objective indication. If he does, there may be no reason for a second opinion. If he does not, then there's a need for a second opinion because that physician is not advising the patient well enough. It is not wise for patients to seek second opinion all the time, only as needed or as indicated. There are benefits as well as potential harms in second opinions. A benefit is the facilitation of problem solving and decision making. Potential harms could be confusion because of so many differing opinions, either getting the wrong advice, doing the wrong problem solving and decision making. Simply going by plurality, 3 against 1, 4 against 1, something like that, plurality of opinions is not as strong, not to say valid, a reason for seeking a second opinion compared to the foremost indication mentioned above. The foremost indication as mentioned is that a physician is not explaining the process well. Going by plurality of opinions is no assurance that the recommendation is correct or should be adopted. One may end up choosing the most popular medical opinion because of the plurality rather than the most rational one backed up by good processes. So if one seeks second opinion, beware of the danger of seeking from physicians who do not use the patient management process to explain and advise. The advice given may be just based on current trends and fad and not based on an in-depth analysis of the patient's actual medical conditions, inherent psychological makeup of the patient, and not based on concrete medical data, information, and evidences. So I'd like to end this pep talk at this point. Okay. The takeaway in this pep talk that are related to patient empowerment are the following. Understand the peculiarities and limitations of medical practice as they affect patient management process so that you will not be frustrated with the outcomes. Be ready to ask questions if the physician is not advising you properly and adequately on the peculiarities and limitations. Participate actively and fully in the problem solving and decision making of your health concern with your physicians, factoring in the peculiarities and limitations of medical science and practice. And lastly, the last takeaway is to master the peculiarities and limitations of the medical science and practice as they may help you in some way in deciding for your own health concern in consideration of the oddities. This is one other way of gaining greater control in your health concerns and issues. Now, before we go to the question and answer, or picture taking first and question and answer, I just like to add something here. So just an announcement. Okay. August 9 was the other day. Okay, I updated the design and development plan of the ROJoson PEP talk. I have transformed it formally into courses. Okay, so there are three types of courses. You have the core course here. Okay, and then you have the health disorder courses, and then the health issues courses. Okay, so you know the reason why this is illustrated like a coronavirus, okay, because this was formulated at the time of the COVID pandemic. Okay, so this is the core course. So coronavirus, there are spikes. So these are the health disorder courses, health issues courses that are being represented by the spikes. Okay, so the core courses includes the following: patient empowerment program, which we have completed. Now we have completed, this is the last session for the patient management process. Then the rights in patient empowerment, which will run for another 2 weeks, and then staying healthy and contented. And the last, this will be the last module on this PEP and this core course. So just to recall your memory, okay. So those who have undergone, who have attended the patient empowerment program module, we talked about what is patient empowerment, strategies in patient empowerment, when is a patient empowered, okay. Then as to the module on the patient management process, okay, overview, clinical diagnostic process, paraclinical diagnostic process, selection of treatment process, advice to patient process. And now we just finished this one, peculiarities and limitations of medical practice. Okay, so 2 more core courses will be upcoming. So next week we will be talking about rights in patient empowerment, which will be which have 2 sessions: basic rights, and then patient autonomy and advanced directive. And then the last course for this, the last module on this core course will be how to stay healthy and contented. So first module will be on introduction and intentional living plan, healthy lifestyle plan, screening and periodic health check, early diagnosis and early treatment, and first aid and basic medical care. So all of these comprise this so-called PEP core course, the one on the center. So today is August 14. So we hope if we continue it on every Saturday, we hope to end the last session for the core course on October 2. Okay. So at the end of the October 2, for those who have completed all the OLETE, I will be issuing certificate of proficiency in patient empowerment. Okay, so this is for the entire core course. Okay. Now for the health disorder courses, so these are sample courses. Okay, so we have gone through COVID-19, that's done. Okay, I won't repeat it anymore. This is despite the search. This is the 3rd search that we're having now. Okay, so I just leave it to the public to read my pep talk in the internet. Okay, then another sample course of health disorder course will be cancer, breast disorder, thyroid disorder, skin and soft tissue disorders. Okay, there will be more. Okay, there will be more. Okay, example of health issue courses will be end of life management, okay, which is also very important, palliative care, use of supplements and vitamins, patient-centered care, unnecessary operations, unnecessary medications. So these are just sample courses which I still have to formulate. So at the end of the, somebody who will finish the core course plus 2 courses from the health disorder courses and 2 courses from the health issue courses will be issued now a certificate of mastery. Okay, kanina, certificate of proficiency. So this time it will be certificate of mastery in patient empowerment. Okay. So before we leave, before I formally end this pep talk by PowerPoint presentation, I'd like to remind everybody again, take the online learning evaluation test exercise for mastery of learning and have a perfect score to get the certificate. Okay, I have placed the link in the chat box. I'm going to place the link also in the Facebook and Viber group. So I hope I have empowered you to have a greater understanding of the peculiarities and limitations of medical practice that affect the patient management process. Okay, so this ends my slide presentation. So we will now have a group picture taking before we start the question and answer and interactions. Please turn on your video and show your beautiful faces now. Ready, get set, get all your pictures, video out. I'll start with page 1 muna. Mas kompleto yata yung page 1. Okay. Okay. 1, get set, ready, go. Give me a second to save it. Then page 2. Page 2. Okay. 1, 2, 3. Okay. Save it. Okay. So the floor is now open for questions, comments, suggestions, etc. You can place your questions on the chat box, or you can raise your hands through the, there's an icon there, okay? Or you just unmute yourself and shout out your questions, okay? Any questions? We still have 20 minutes to go. I hope we can finish this on time, because I know some of you will have something to do at 3 o'clock, like Chuchi Quevedo will have a prayer meeting, okay? Any questions from the chat box? None?
None yet.
Okay. So if none, try to recall your experiences in the past. You have been patients before. Okay. So what were the challenges that you encounter? You can share your experiences. Were you being advised properly? Okay. Were the advice always may mga maraming uncertainties sa mga advices, no? Okay. Were you frustrated with the uncertainties? No. Any questions?
Doc, I have question po.
Good. Francis. Yeah.
Francis po. Yes.
Yeah.
Doc, regarding sa experience sa doctor, like, for example, yung husband ko, Doc, meron kasing cases na parang, yung doctor parang, yung pag nag-ask ka ng question, very limited yung limited yung sagot, or parang kapag nag-entertain siya limited yung pag-entertain niya ng question. Parang, di ba, based kanina doon sa natin, sa lecture, paano niya makukuha, di ba, yung diagnosis if hindi niya makuha lahat ng dapat na makuwang info from the patient, parang gano'n. So how do we kasi minsan Dok parang sina-shout out ng doctor minsan pag marami kang question, parang gano'n. I mean, baka kasi maraming nakapila or baka kasi paulit-ulit or something. So parang how do we kaya yun Dok? Pag parang hindi rin naman mainis yung doctor or parang maging at ease din at the same time. Parang ganun.
Okay. So, okay, that's a reality. That's a reality. Okay. Number one, probably we cannot totally avoid it now. Okay. Kasi number one, doctors are also people who have different personalities. Yung iba madaldal, iba tahimik, no? Ganun.
Yes,
No? Okay. Okay. Number two, ang training namin are not standardized, no? Okay, iba-iba, no? Okay. Ang pinaka-importante, makapasa ka lang sa examinations, pwede na, doktor ka na, di ba? Pero yung skills is not really well emphasized, no? Yung mga skills, no? Kung may standardized lang sana yan, but I think which is also not possible, not totally, no? At least baka mas marami, more than what we have at present, na maraming nag-explain, no? Sana, ganon, di ba? Okay. So, I guess the best solution, kaya I think, okay, this is my personal opinion, my own thinking. That's the reason why I created this patient empowerment program, no, to help you, no? Okay. So, I have shown you some guides on what to ask. Kayo na magtatanong. No? Okay. Pag hindi ini-explain, tanong ninyo. So when you know what question to ask, more or less direct to the point na kayo. Di ba? Direct to the point ang tanong. Kaysa pag wala kayong previous tips from me, no? You ask, although you are free to ask a lot of any questions under the sun. Di ba? Okay. Anything. Di ba? Pero kami sa mga doctor, kasi tao rin sila. Kasi baka naiinis sila sa mga tanong, di ba? Kung pasikot-sikot, no? So if you know some questions to ask already based on my lecture, no? Tanungin niyo kaagad, no? So most likely matatauhan yung mga hindi nag-explain, no? Kung minsan magugulat lang sila, ay marunong pala itong pasyente nito. Marunong magtanong, no? Okay? So mapipilitan sila sumagot, no? No? So that's my advice, no? Just take note of the patient's management process and then take note of what questions to ask, no? Okay? Then ask yung mga pertinent questions na lang, yung pinaka-importanting questions, okay? An example is, okay, we have discussed this before, no? Do not ask for the possibilities. Sabi mo, Doktor, possible ba ito? Ganon. Okay? Kasi sasagutin ka talaga, yes, anything is possible, no? Okay. So tatanong mo, what is the probability of this being the disease? What is the probability of getting a successful management? Ganon, no? Okay. So,
the water.
Yeah. Okay. I mean, nag-interrupt. Okay. So, did I answer your questions?
Yes, Doc. Opo.
So may mga, okay, just take note of the questions that you have to ask your doctors. Then
direct yung questions.
Direct questions. No? Okay.
Okay, Doc. Kasi I understand naman, Doc, talagang meron gano'n. No? Hindi talaga ma-entertain or something.
Kung despite na hindi siya sumasagot, you have the right to have second opinion. Tama?
Yes,
You have the right second opinion, you can change to another doctor. Okay?
Okay, Doc. Thank you po.
Okay. Good questions. Okay. Ano pang tanong? Abet, anong may tanong? Voluntary went. Okay. May tanong dito, mukhang mahaba ito. Jocelyn, I saw one question. Unmute ka, Abet. One OBGYN who knew I was so eager to get pregnant told me to take Provera when she saw in my ultrasound result that my uterus was enlarged. She even did a physical examination on me. I didn't take the Provera pills, but voluntarily went for a pregnancy test without her prescription. The result was I was pregnant all the while. I went back to the OBGYN and told her of the misdiagnosis. If I followed her instruction, it will be equivalent to a miscarriage. Okay, so that's I guess that's a comment by Jocelyn T. Okay, so as I said, the number one, the limitations of the doctors is that there's nothing absolute in the diagnosis, no, but dapat the doctor should not stick to one diagnosis. Always think of the other possibilities, no? Even though kahit na 99% sure na siya on his own, meron pa 1%, you always have to keep on monitoring for the possible 1%, no? Ganon, no? So, but if she is the type that she's totally sure siya na, ay, dapat ganun lang, one track mind lang, one diagnosis, she's going to get into trouble. Okay, as you said, misdiagnosis. Okay, misdiagnosis means wrong diagnosis. No, okay. So, kaya nga, okay. I suppose this happened before our pep talk, so I must congratulate Jocelyn for being empowered as a patient already. No? Okay. So for those who are attending my pep talk today, I hope you can do the same. You do the same. Okay. You learn something and do what you have to do when you're faced with such situations. No? Okay. Okay. You can ask the doctors what's your second diagnosis. Okay, right there and then kung talagang sinasabi niyang isa lang, no other diagnosis, huwag kayong maniwala. Okay? Okay. There's no such thing as one and only diagnosis. There's always other diagnoses. You just have to weigh the probability, the degree of certainty. No? Okay. And then kung sinabi niyang kung sinabi niyang wala nang follow-up, okay, ganun yun. Ha? The other thing I want to emphasize is that all the patients that I've seen, whether in my clinic, in my telemedical, I usually have a follow-up. Okay. The reason why I want to have a follow-up is because I'm not 100% sure of what is happening. Okay. I'm not 100% sure of the diagnosis. I'm not 100% sure of the outcome of the treatment. Okay. So I insist on a follow-up. No? Okay. So when I insist on a follow-up, that implies that I am very much concerned with what will happen to you. I might be wrong. Okay. Okay. Or na parang I want to have a constant communication. I want to see it through that you get well. Okay. If there is some kasi pag follow up, makikita mo yung new development, di ba? Okay, new data coming in. Okay? Pag sabihin mo, nagkamali ka ng first one, honest mistake, kasi sabi ko, educated guess lang yan, and no guarantee that it's the only diagnosis. Once you have new data coming in, you change it right away. The doctors will have to change it right away. No? Okay? So that's why I think I have a article, Ask Dr. ROJoson, yung misdiagnosis, and there are two terms there, misdiagnosis, MIS diagnosis. Now that's a wrong diagnosis. MISSED, misdiagnosis means hindi nakita. Okay? Nalaktawan. No? So magkaiba yung dalawa. No? Okay? So doctors are prone to commit these mistakes, no? Okay, because of the uncertainties in medicine, no? But I will only tell you that you can complain against the doctor if he does not follow you up. He does not continuously follow you up to check for any other possibilities. But if he continuously follow you up to look for new development, no, he is not at fault. Okay, he is not at fault. You can adjust it right away. Para kung meron kong konting misdiagnosis, papalitan niya kagad before it's too late. No? Okay? Does that answer your question? Jocelyn?
Yes, Doc, thank you.
Okay.
Okay. There's another from Delhi Tan, Delhi Liam. Doc, may isa kaming employee, 46-year-old. Magpapabaksin siya last month pero nakita na high blood siya, 200/90 at pinainom siya ng med and pinarest siya pero hindi bumababa ang BP. Same pa rin. Kaya di siya na-vaccine. Pinatake namin siya losartan for 5 days, bumaba konti to 170/91. Paano nila pabababain itong BP? Powder ba? Pwede ba siyang ma-stroke anytime? Walk naman daw siya, wala naman daw siyang na-feel. Hindi nahihilo or no symptoms at all. Talaga ba sa duo niya na nababaon kataas?
Talaga ba sa duo? Ano yun?
Duo, I don't know. Was talaga ba? Deli, can you explain about this?
Talaga ba sa duo?
Yung
So,
sa dugo niya.
dugo.
Oo. Mali-mali. Sa dugo ba niya na talagang mataas ang BP or kasi ayaw pa bumaba hanggang ngayon eh. Pero hindi niya alam na high blood siya kung hindi siya magpapabaksin. Yun naging 220 pa nga tapos pinainom siya ng gamot, pinarest. Bumaba konti 200 kaya inayawan na hindi na siya binaksin.
Okay, yung blood pressure. Okay. Blood pressure. Andyan si Rhea. Okay. Rhea Bernardo, andyan ka pala. Okay. So we just had we have an experience with blood pressure recently. No? So yung blood pressure, okay. I think somebody also consulted me on blood pressure other than Rhea. Okay. Yung blood pressure, hindi man maraming ano yan eh. Maraming issues yan. No? Okay. One is yung sinabi mo nga, hindi niya alam na may high blood siya. Then, nung magpapavaccinate siya, nakita mataas ang BP. So it was discovered na mataas. No? So the question is, talagang bang may high blood siya? No? Okay. Kung one determination lang, the doctors usually do not conclude na may hypertension as the disease. No? So you have to take a series of blood pressure, no? At least 3 times, 4 times, no? Okay, in different situations, nakapagpahinga, no? Ganon. Kung mataas pa rin, siguradong meron na, okay? And then, kung meron na, iba-iba yung gamutan, no? Maraming gamot dyan. There are about 100 medicines anti-hypertensive dyan, no? Okay? So remember, also, aside from having a lot of these medicines, we don't know which one is the most effective for a particular person. Kanya-kanya yan, eh, no? Baka may hiyang, may hindi hiyang. No? So it will take some time, no? Bago mawala. No? Okay. So you have to allow 1 week, 2 weeks before talagang bumaba. Unless talagang you have to give him a medicine that will bring down the blood pressure right away. Pero hindi man maganda yon, no? Kung bigla mo ibababa, no? Okay? So dandahan lang ipagbaba din, no? Kasi yun ang pagbiglang baba, yan ang pwede mag-stroke, no? Okay? So kung palaging mataas ang BP mo at wala kang nararamdaman, usually during that time, hindi yung wala naman danger mag-stroke yun at that time, no? It's when mataas ang BP mo o yung BP mo this level biglang nag-shoot up na sobrang taas, no? Okay? So pwede ka mag-stroke kagad, no? Okay? Yung biglang taas ang usually nag-stroke, no? Yung o kaya biglang baba, yung talagang mababa, no? Okay? So kung mataas na baka sa kanya, matagal naman yung blood pressure niya, matagal na, hindi niya hypertension na matagal, hindi na niya napapansin, no? So just take your time and bring it down, no? So usually mga 2 weeks, 3 weeks, dapat bumaba na yan, no? On the
Hindi,
average.
more than ano na, 1 month?
Ha?
More than 1 month na.
Baka yung gamot na, papalitan yung gamot. Anong dosage?
Palitan.
Dosage or ano?
Kind of medicine.
Hindi.
Anong, anong gamot ang iniinom niya?
Losartan?
Oo.
Losartan.
Yun lang.
Oo.
Pag hindi bumaba, usually dinadagdagan pa amlodipine, losartan and amlodipine. No? Ganon.
Okay.
Okay.
Oo.
So ititimpla lang yon, no? Okay.
Sige.
Timpla lang.
Thank you, Doc.
Okay.
Okay, there's another question from Aida Antonio. If every cancer is peculiar, is it true and correct for a doctor to say na stage 1, 2, 3, 4 or nothing to be done na po? Can it be based only on paraclinical diagnosis like the biopsy, CT scan?
Okay, tapos na?
Yeah.
Ano yung stages?
1, 2, 3, 4.
Or
Is it
nothing?
true? Yeah, is it true and correct for a doctor to say na stage 1, 2, 3, 4 or nothing to be done na po?
Okay. Okay, let me put it this way. Medyo nagugulan ako sa question mo. No? Okay. Is it true and correct to say for doctors to say stage 1, 2, 3, 4? Okay, let's stop there muna. Okay. Yes, the doctors have basis for saying, let's say kung na-diagnose na cancer, no, they have a way of staging. No? Okay. May stage 1, early stage. No? Stage 2, a more advanced stage. Stage 3, more advanced. Stage 4, the most advanced. Okay? So kung merong, if the patient's in the stage of the most advanced, sasabihin niya stage 4. Yung mga, especially those cancer na may spread to other parts of the body, yung tinatawag na metastasis. No? So if the picture is there na merong spread to other parts of the body, the doctor will tell the patient, you have stage 4. No? Okay? Kung yung localized lang yung cancer, maliit lang, baka sabihin sa kanya, the doctor will tell the patient, you have just stage 1. No? Ganon. So pwede. No? Okay. Or nothing to be done na po. Can the doctor say nothing to be done na po? Yeah, okay. The way to answer this is, okay, kung talagang advanced na, okay, the chances of being cured is very, very small, and for practical purposes, no, wag na lang. Pwedeng naman i-advise ng doctor, just go for palliative care. No? Wag na lang. Okay? Nothing to be done. When I say nothing to be done, wala nang anti-cancer aggressive treatment. No? Okay? Pero of course, the doctor will have to advise the patient properly. No? Okay. So yun ang sitwasyon. Pero kung gusto ng pasyente, go all out, he has all the money to spend, no? Okay. You want to grab the 1% chance of being cured, so-called cured, no? Then go ahead, no? Okay. Can it be based on the paraclinical diagnosis? No, everything, the diagnosis will have to input the clinical, paraclinical diagnosis, lahat-lahat. Hindi lang pwedeng biopsy, CT scan lang, na lahat, na. Kasi as I said, lahat, there's no absolute certainty in all the tests, clinical, paraclinical, histopathologic, even at death. When you die, sometimes when we die, di ba, may mga diagnosis still uncertain, di ba? Hindi alam, no? So in the end, we have to bring all this data together, analyze it, and then come out with a most likely diagnosis. Okay?
Okay. The question that Mrs. Jocelyn T. asked a while ago happened before her first child, he says.
Okay, empowered. Talaga, marunong talaga si Jocelyn. Empowered yan. Okay.
From Rochelle de la Cruz. Doc, is it always necessary to have the RT-PCR test done If you have COVID-like symptoms, can it be observed or managed at home first?
Okay. Okay. Before I answer that, okay, tinitingnan ko lang sinong ano. Kasi some of the attendees here, I think I have the same situation, no? Plus the fact that I have written something on this already, no? Okay. So, yeah, okay. It's, okay. Once you have, ulitin ko na lang, ha? Let me reconstruct para short lang. Once you have symptoms of tinatawag na upper respiratory tract infection, like cough, colds, no? Okay. Sneezing, sore throat, no? Ang suspecha mo, it's either COVID or flu. Okay, yan ang pinaka-common na dalawa. Or the other is kung may allergy, pwede rin, di ba? Okay, but let's remove the allergy na lang muna para ma-simplify ang sagot ko. So let's just consider two, flu and COVID, no? Okay, because of the era of pandemic tayo ngayon, we think of COVID as number one. Okay? Because maraming may COVID, di ba? Kasi kung walang COVID ngayon, we think of flu. Yan ang primary diagnosis, no? Okay? Now, do you have to, the only way that can distinguish COVID-19 from flu is through a test, RT-PCR, okay? Okay? Kung RT-PCR is positive, yun na yun. Kung negative, now, pwedeng flu, pwedeng something else, other virus infection. If you want to really know what it is, then, basta hindi na COVID, you have to make another test for flu. Another test yon, di ba? Okay, if you really want to know. Kasi yung flu virus flu influenza is caused by influenza virus. Okay? Then yung common colds is caused by rhinovirus. Iba-ibang virus yan eh. If you really want to know the exact virus na nagkakos, no? Pero mahal, no? Okay? So, going back, COVID versus influenza virus, okay? Yung sinasabi ko, if the management would be the same, no, you don't need to have the test anymore, okay? So you just treat them the same way. Di ba sabi ko, the two processes that we use is, number one, okay, how certain are you with the diagnosis, and then what is the comparison of treatment of the first and second, no? Okay, so you're not certain, let's say, because of the era of pandemic, more or less, sabi natin, 80% versus 20% for flu, okay? So 80-20, not sure, okay? But the treatment is the same. Home management lang, treatment, no? Sa bahay lang, no? Okay, so you conclude that you don't need the test, okay? You don't have to go for the test, okay? The only, may mga exceptions to the rule, sabi ko. The exceptions to the rule that you need to have the test is one, kung the government require you to have the test. Okay? The government, the LGU. Okay? Wala tayong magagawa. Number two, if your employer require you to have the test because he wants you to go back to work right away. Okay? Pero kung wala itong dalawang condition, wag na lang kayo magpa-test. Just stay home and then wait for the quarantine period to pass. And then, kung gumaling kayo, it's immaterial now na whether it's flu or COVID. Okay? So don't split hair anymore. Okay? Okay? Unless you really want to know and spend. No? Ganon. Okay? So yung mga mild symptomatic na COVID, no, you can do home care. No? Home care sa bahay. Best supportive management. Then quarantine for about 10 to 14 days. Okay? Okay na?
Okay, there is another one from Mr. Ed Ramirez. Are doctors following Western medicine allowed to prescribe medicines that have not been accepted by the FDA at that particular time? It seems like some doctors from other countries are willing to try untested medications under the standards of Western medicine for the benefit of the patient.
Ang tanong is, can Can the doctors do that? No, yung mga not approved by the FDA. If it's available, okay, again, informed consent. Informed consent. No? Okay. Kung gusto ng pasyente, no, and the doctors believe that it can be upheld, and then the doctors will tell that it's not yet approved. Okay. So, gusto ng pasyente, no? Then, it's either if it's against your belief, then you don't prescribe it because you might be sued for it, di ba? But if you have a sign, may mga consent form na papayag ako dito, no? You cannot sue me, no? Then go ahead, take it, no? Okay. So, pwede. Are you referring to a specific item? Ivermectin?
Ivermectin.
Ed? Okay. So,
He
then,
says, Doctor, he says, I want to play safe.
okay. Okay. Now, as I said, actually, kahit na yung multivitamin, sinasabi natin di kailangan, but everybody's selling it, di ba? Okay. So everybody in the world, all over the world saying that multivitamins are useless, di ba? But everybody's selling it, di ba? They put it under the food supplement item, di ba? To circumvent the drugs, di ba? You know? So what can we do? The patients wants it. So bahala sila, di ba? Okay. So we cannot, the doctors cannot really stop the patients from not taking it. No? Okay. So we just have to educate the doctors, no? The patients. No? Okay. Any more?
Yeah, from Lolit Ramirez. After 14 days of quarantine, can we say na di na contagious ang patient na nag-positive?
Yeah, as long as wala ka ng symptoms. Wala ka ng symptoms at 14 days, no fever, no cough, no ano, no? Okay, usually wala na. But sometimes the cough will still be there, but as long as the fever has gone down, other symptoms, at 14 days, usually wala na. No? Again, may exception to the rule. Baka may 1% na makakalusot pa. Okay, if you want to be sure, extend move up to 21 days and make sure na talagang totally wala ka nang nararamdaman.
Okay, from Ma'am Jocelyn P. Just to share, one friend in Manila tested positive in RT-PCR test. The next day, she was fetched by the barangay and brought to isolation center. And another friend in QC had the same experience. Positive COVID patients cannot have self-isolation in their own homes now. They make those with COVID symptoms not to hesitate going to have the PCR test done before. This makes those with COVID symptoms now to hesitate going to have the RT-PCR test done.
Okay, correct observation. No, correct observation. Diba? Yeah, a lot of people are hesitant to have the test done. No? Especially with RT-PCR kasi naka-register yan sa LGU. No? Okay. So if you don't like to be caught in that situation, no, as long as you're, basta meron lang doctor to guide you. Okay? At parang home management guide. No? Pwede na. No? And then, kung habang gina-guide ka, monitor, suddenly you experience some difficulty, advancement of symptoms, that's the time, the doctors will advise you probably oxygen, or kaya hospitalization already. No? Okay. Any more?
From Lolit Ramirez, thank you, Doc.
Okay. Okay. So it's 3:10. Unless there are other important questions, habang questions or important questions. Meron pa ba?
Nothing more. Just
Okay.
thank you, Doc, from Jocelyn P.
Okay. So it's 3:10. As I said, I don't like to make this pep talk more than 1 hour or more than 1 hour and 30 minutes now. So we'll call it a day now. So officially we end. Now those who want to stay can stay on and have chit chat with me or ask other more questions. I will probably call this off at 3:30. 3:30. But those who wants to get off from this pep talk, this Zoom, pwede na. I won't get mad at you. Okay. Pwede na. Okay.
Thank you, Doc.
Welcome.